Hi, good afternoon, everyone. A warm welcome to our Facebook Live talk today. I am Renu Shah, a medical professional specialist, product specialist from DKSH, will be the moderator for today. We are honored to have an experienced consultant, Dato Dr Linda, a consultant ophthalmologist from Assunta, to give us a talk today. Dato Dr Linda graduated from MBBS in University Malaya 1983 and began her career pursuing her housemanship at University Hospital Kuala Lumpur in 1984. The highlight of Dato Dr. Linda's career saw undergoing her fellowship training in glaucoma subspecialty with world-renowned glaucoma surgeon Dr. Robert Rich at New York Eye and Ear Infirmary in New York, USA. Besides being a glaucoma specialist, Dr. Linda is well versed and with comprehensive and general ophthalmology, and it is skilled and experienced surgeon. She has performed numerous cataract surgery, squint surgeries, trabeculectomy, as well as laser treatment for diabetic retinopathy and other major minor surgeries. Before I proceed, a kind reminder: if there's any question during the presentation, kindly comment at the comment section below. Without further ado, let's welcome Dr. Linda on her topic, Do you know glaucoma? A silent thief of sight.
Thank you, Ranusha, for the kind introduction, and thank you for inviting me to speak to you on this platform. Good afternoon, ladies and gentlemen. Welcome to join us for this talk on Assunta Live talk. And my topic for today is glaucoma. Do you know what is glaucoma? Glaucoma has often been known as the silent thief of sight. So this picture shows that the children are in the central part of the vision, but the peripheral part of the vision is black, such as over here and over here. This is a typical visual field of a glaucoma patient. Now, before we go on, we need to know what is glaucoma. From March the 7th to March the 13th every year, it is International World Glaucoma Week. The World Glaucoma Week was started as an initiative to make people know about glaucoma. And why is it so important that we need to know about glaucoma? It is important because glaucoma is a chronic eye disease and it causes damage to the optic nerve. What is the optic nerve? If you look at the picture of the eye, the optic nerve is the nerve that goes up from the back of the eye, and from the back of the eye, it goes to the brain. And this optic nerve contains all the nerve fibers from the rest of the eye and is concentrated at this point which it exits the eye. So it is important because every nerve fiber from inside eye will have to go through this nerve. So when there's a damage to this part of the nerve, it can cause severe damage to the person's vision. So glaucoma most frequently results in serious vision loss, and it has been known to be a leading cause of irreversible blindness. I would like to stress at this point that what is irreversible blindness? Irreversible blindness means that no matter how hard we try to treat or what we do, once the damage occurs, there's no way of reversing. A patient may have a momentary loss of vision because the cataract gets much more and more and cause patient to have a decreased vision. But when the cataract is removed, in contrast to glaucoma, the patient can still retain good vision or recover good vision. So what do we know about glaucoma? Glaucoma is not one disease. Glaucoma has been known to be considered as a group of diseases. And in order for us to make a diagnosis of glaucoma, we do not just depend on pressure of the eye alone. The pressure of the eye is known as intraocular pressure, which for short form is intraocular IOP. And for a patient to be diagnosed to have glaucoma, usually we need to have 2 or 3 of these following characteristics. So the patient must show that there is an increased intraocular pressure. And we must also demonstrate by looking at the nerve that there is nerve head damage. That means the optic nerve that comes out of the eye must show there is damage. And the patient must demonstrate that there is visual field loss, that means functional loss. So glaucoma has a wide definition. So you can have ocular hypertension. Ocular hypertension means the pressure in the eye is high, but the patient may not have nerve damage. The patient may have glaucoma itself. They can have 2 out of these 3 damage to the visual field damage to the optic nerve, as well as raised intraocular pressure, or normal tension glaucoma, whereby the pressure of the eye is actually within the normal limits, but the patient shows damage to the nerve fiber as well as damage to the visual field. So now, having said all that, who are the people at risk for glaucoma? As you can see, glaucoma is a basket full of risk factors. People who have been known to have more than 40 years old are at a higher risk. As we know, the older the patient is, the higher the risk of getting glaucoma. That is why we stress on the fact that the older you get, you must remember to go for an eye checkup. Certain races are more prone to glaucoma. Like for example, the Eskimos. Eskimos are more prone to angle closure glaucoma, whereas the majority of other patients, other races, can often get primary open angle glaucoma. If you have somebody in the family who has got glaucoma, it is very important that you have to go for a screening to make sure that you do not have glaucoma. The risk of getting glaucoma is higher if there is somebody in the family with a close relative who has glaucoma being treated. When a patient has vascular disease, such as hypotension, or patient has vasospasm, in vasospasm, patient often presents with cold extremities. That means that even though it is a warm day in a warm environment, the patient often feels cold in the hands or in the feet or in the fingers. So that's a sign of vasospasm. Patients who have hypotension or even patient has sleep apnea, they are those people who have very high risk of developing glaucoma. Diabetes is very common. We often neglect diabetes. A lot of times patients may have diabetes, but hardly go for any eye checkup. Diabetic patients may get diabetic retinopathy if the diabetes is not well controlled. And eventually, when the diabetes retinopathy in the eye progresses as the diabetes goes out of control, the patient may develop proliferative diabetic retinopathy, leading to bleeding inside the eye. And as an end stage, the patient develops uncontrolled neovascular glaucoma, or glaucoma which arises because of abnormal blood vessel formation. And there are many people who are quite young but who have lost the vision due to uncontrolled diabetes. So diabetes itself is a very important risk factor. Those are the general factors that the person has. But what about the eye factors? Are there any special eye factors in the eye that may make a person prone to glaucoma? Yes, there is. Patients who are normally, in a normal context, have pressures higher than normal. Normal pressures are in the range of 10 to 21 millimeters mercury. And anybody who can present normally at any checkup of more than 20, like 25, 26, they are at a higher risk of potentially developing glaucoma as they grow older. Now, nowadays, a lot of patients who have refractive error, especially very short-sighted vision, they want to be spectacle-free. So they go for LASIK surgery. But what happens in LASIK surgery is that to reduce the power of the eyes, the laser has been done to cut down the thickness of the cornea. So when the cornea thickness becomes much less due to this LASIK, it makes it very difficult for us to measure the proper pressure. So if a doctor who is unaware that the patient has had a LASIK done before, he or she may diagnosing a patient with glaucoma because relatively the pressure will be low when they check the patient who comes for screening. So it's very important for anybody who has had LASIK done before or refractive surgery. It is important for them to mention it to their doctor when they go for an eye checkup. Some patients are born with naturally large nerves, and subsequently, when the nerves are large, the cup-disc ratio also becomes large. So when those patients with large cup-disc ratio makes them at a higher risk of being a glaucoma suspect and developing glaucoma. Sometimes some patients, for no reason, or maybe because they have diabetes or they have hypertension, they may show some form of disc hemorrhage around the optic disc. What the disc hemorrhage indicates is that there is ischemia or there's not enough blood supply to the eye, and subsequently because there's ischemia, the demand of oxygen arises and the patient may develop abnormal new vessels, and these abnormal new vessels lead to neovascular glaucoma. In patients who have glaucoma also, this hemorrhage always signify that they are at a higher risk of progressing. So what is the normal intraocular pressure? As mentioned earlier, the normal intraocular pressure is between 10 to 21. Some books will quote it as 12 to 21, but majority of us will take it as 10 to 21, plus minus 1 or 2 millimeters mercury. The patient must understand that the person is just like blood pressure. The blood pressure doesn't stay constant, the same pressure the whole day. So the eye pressure will also be the same. It varies from morning till night. And at different times of the day, the pressure may be higher or lower than the usual. So patient must understand that even though they take medication, the pressure will not be constant the whole time. It still fluctuates. It's the fluctuation in the blood, in the eye pressure that causes the damage to the nerve. So the idea is that it must important that the patient do not have intraocular pressure that varies too much over the whole day. So most of the time before if we are unsure whether this patient has got glaucoma or not, we tend to do pacing. What we mean is that we check the patient's intraocular pressure the whole day and we see what is the highest and the lowest for that day and how much the difference will be. If there's a lot of fluctuation, more than 4 millimeters mercury per day, that means the patient is at a higher risk of fluctuation of intraocular pressure for that eye. And that makes it higher risk of getting glaucoma in that eye. Okay, when we talk about glaucoma, which part of the eye are we concerned about? So let us look at the structure of the eye. So this is the cross section of the eye itself, the globe, and you can see that this particular region is where we are concerned about the intraocular pressure. This is what you call the anterior chamber angle, and this is where the optic nerve is, and this is the place whereby all the nerves go flow out of the eye into the brain, and this is the optic nerve. So we take a magnified view of the anterior chamber angle. So what we see here is that this is the cornea, this is the sclera, this is the ciliary body which produces the aqueous that maintains the shape of the eye and produce nutrients to the rest of the eye. So around here, it goes out through the anterior chamber angle. This anterior chamber angle has small little openings like a colander, whereby it sees the fluid that goes out. So the fluid that is produced by the eye, the amount of fluid that is produced by the eye must balance the amount of fluid that is removed from the eye. So in cases whereby the drainage system is affected, the intraocular pressure builds up in the eye because there is imbalance between the production of the aqueous with the removal of the aqueous. So this is an important part of the eye which is called the anterior chamber angle formed by the cornea and with the iris. So this part we have to make note of it for us to help us to diagnose whether the patient has open angle glaucoma or angle closure glaucoma. There are many types of glaucoma. There are as many as 40 different types of glaucoma. But glaucoma can be differentiated for us to understand it easier by diagnosing it according to the angle opening. When the angles are open, we diagnose it as open angle. And when the angles are narrow or closed, we call it as closed angle glaucoma. For open angle glaucoma and closed angle glaucoma, we have primary, meaning that there's no underlying cause, and we have secondary, such as diabetes, injury, or steroid use, which can give rise to pressure rise in the eye. Under the others group are things like congenital glaucoma, where a baby is born with glaucoma, or juvenile glaucoma, whereby the child develops glaucoma as the child grows older. Whatever the type of glaucoma is, most of the time the patient will come with when the patient comes with, for a checkup, what are the things that we need to ask in the history? So we ask the patient regarding visual blurring and discomfort. A lot of times, most of the patients are symptomless. They do not have any symptoms at all. But in case the patient complains of blurring of vision and discomfort, we must make sure that there is no closure of the angles or narrowing of the angles and other specific conditions like certain eye diseases which may produce this kind of discomfort and blurring. And when patient complains of colored rings around lights or halos, especially at nights when they look at the car headlights or when they look at the bulbs in the house, we must make sure that we check the pressure to make sure we can differentiate it from migraine, which also can cause halos. A lot of time patients may say they have glare, especially at night when they look at oncoming cars or at night when they are driving or watching TV. We have to make sure that they don't have glaucoma because frequently the patients who have cataract and migraine may have glare as well. Glaucoma patients often have difficulty adapting from light to dark. That means when they are from the outside of the house whereby the environment is bright and they go into the house which has a dark environment whereby the lights are not on, they have difficulty adapting to moving around. It is only when they are familiar with their own surrounding, like their own home, that they do not really notice the light-dark adaptation problem. Glaucoma patients often have problem tracking fast-moving objects like the golf ball or tennis ball when they're playing the game. These signs, these complaints should make us think of glaucoma. When you talk about primary open angle glaucoma, we look at this picture, whereby again we're looking at the anterior chamber angle. Here, this is the iris, and this is the cornea, and this is what you call the anterior chamber angle. As in this picture, you can see that the angles are open. The primary open-angle glaucoma are the most common form of glaucoma, and here the pressure in the eye goes up even though the angles are open, and this is because there is some form of resistance to the outflow of the aqueous. Why it happens, we do not know. It is still unknown most of the time. And the angles and the iris between the iris and the cornea remains open all the time. But the pressure in the eye builds up because the flow it gets there's resistance to the flow of the aqueous outside the eye. So the pressure is goes backwards and causes damage to the optic nerve. However, in this condition, the glaucoma progresses slowly. And because it progresses slowly, the patient does not feel any pain in the eye and do not notice damage to the eyes until fairly late. Primary open-angle glaucoma is the most prevalent type of glaucoma. When we check the pressure, we find that the pressure is very high. It can be between 20s to 30s. It can be more than 30s. It can be more than 40s. Often, when we look at this patient, they already have progressive damage to the optic nerve. And a lot of times, the patient have bilateral visual field loss. One eye may be more than the other. It's seldom that we have one eye normal, whereas the other eye shows advanced glaucoma. And when these things happen, when the patient comes in such condition, whereby one eye is already advanced glaucoma and the other eye is normal, we have to look for things like steroid-induced glaucoma and tumors, and also we have looked for things like using of steroids. So what we have to know is that in primary open-angle glaucoma, most of the patients do not have symptoms until very late. When they come to see you for blurring of vision, it could mean that it's very late. A lot of times, patients with glaucoma come and tell you, Doctor, I can still see very well. Yes, you can see very well, because when we check the vision, we are checking for visual acuity. That means to say that we are checking to see how much you can see. But when we talk in terms of glaucoma, we talk in terms of visual field. And what is visual field? The visual field is your ability to see around you. Where if you close one eye, the amount of things you can see above, below, to your nasal side and to your ears, temporal side, how much you can see, that is called the visual field. So in patients who have got advanced glaucoma, it is not unusual that their vision can still be very good, 60/6 or 20/20 vision, but the visual field is damaged. On the other hand, when you have angle closure glaucoma, most of the time the patient is symptomatic. It can be considered as a medical emergency. And why does this happen? This happens very suddenly because suddenly the drainage system closes because the pupils dilate, and then the iris gets punched up and closes up the angle. And why does this happen? This happens in patients who have small eyes or predisposed anatomical or structural conditions, which makes them easier to have a sudden acute attack, meaning that a sudden closure of the drainage system. This can happen when the patient takes medication like medicine for cough, medicine for running nose, or even when the patient sits in the dark and watches TV. Because when in these situations, when the patient sits in the dark to watch TV, naturally the pupil size will become larger. So when the pupil size becomes larger, the iris becomes bunched out or folded over the anterior chamber angle, and this suddenly closes the anterior chamber angle. And because the aqueous inside here cannot move out of the angles, it has a sudden build-up pressure, and this pressure gets transmitted to the rest of the eye, and thus the patient presents as headache. A lot of times patients can come with headache, they can have nausea, they can have vomiting, and usually a patient who has acute angle closure glaucoma is an elderly patient. Most of the time, 4 to 1 patients are female. And the patient may have very red eye, the vision may be very blurred. When you look at the cornea can be hazy, the pupil can be half dilated. This can be considered as a medical emergency because usually patients, besides having headaches, will feel that they can have nausea, they can have vomiting. And when you check the patient's pressure at this time, the pressure can be as high as 60 millimeters mercury. Having said that, you must remember that patient can have acute attack in both eyes at one time, but majority of the time it's really one eye at a time. And one thing to note about is that nowadays, even though we say acute angle closure glaucoma happens mostly in elderly people, we have come across a few young ladies, I would say, stress young people who have acute angle closure glaucoma. And this is from taking medication that help to suppress the appetite because they want to control their weight and remain slim. So we must not forget when a young person comes with high pressure, it could be a form of endoclosure due to this, using all this medication. On the other hand, we have normal tension glaucoma. And normal tension glaucoma is a very common condition in Asian eyes. And in this situation, we find that when you check the pressure of eye, the pressure is within normal. It's within the normal range, but when we look at the rest of the eye, we find that there is damage to the optic nerve and we have damage to the visual field. Why it happens and why people develop normal tension glaucoma is still unknown. But we have postulated that patients who have or develop normal tension glaucoma frequently have a condition such as sleep apnea, they may have vasospasm, they may have migraine. And a lot of times when we check normal patients with normal tension glaucoma, we cannot find any abnormality in the eyes besides the optic nerve damage. That when we do a brain scan, there is no abnormality in the brain as well. On the other hand, there is ocular hypertension, which I mentioned earlier. In this group of patients, the pressure in the eye is naturally high. Naturally high means that it may be more than 24 millimeters mercury, but the patient do not show any signs of optic nerve damage. They do not show any signs of visual field damage. And when you look at them, they look perfectly like normal. But when we check the corneal thickness is an important factor. Because when patients has ocular hypertension, and if the corneal thickness is more than 550 microns, it is less likely they will develop glaucoma in the future. But if they have pressure more than 24 millimeters mercury, or they have corneal thickness which is less than 550 microns, it makes them having more than 10 times risk of developing glaucoma as they age. Lastly, there is such a condition as congenital glaucoma. In our Asian society, when we look at the child's eyes, and when we look at the cornea and the cornea looks very big, they say, oh, very beautiful, the child has big eyes. But beware, big eyes could mean problem. Because when the child is born with congenital glaucoma, the child cannot tell, all it can do is it cries. And when you carry the child, you will notice that the child will be photophobic. That means it will turn away the face from the light and you will try to bury its face on the shoulder of the carrier. So in this type of condition, situation, we find that when we look at the child, you can find that the cornea can be very large. In this case, you can see both eyes are large. And most of the time, because of the high pressure, the cornea becomes hazy. So for congenital glaucoma, the treatment is always surgery because you need to treat the child early in order to save the eyes. But the child will need to be followed up for the rest of its life. On the other hand, we have secondary glaucoma. The earlier conditions which we discussed are mainly primary glaucoma. So when we talk about secondary glaucoma, this is in association with another eye condition, such as a patient may have trauma, and very common trauma is playing badminton. It's not unusual that we have a shuttlecock injury. We see that very frequently. A patient who has had shuttlecock injury or have a squash ball injury or an injury or being punched in the eye can develop a secondary glaucoma as an acute phase, or it can develop much longer in time, maybe many years later, when the patient may have forgotten all about the injury. Okay, the second condition that commonly causes secondary glaucoma is steroid use. This commonly happens in children and adults as well who have allergic conjunctivitis of the eyes. So what happens is that most of the time the child or the adult will have very itchy eyes, and when they first see an ophthalmologist, they may be prescribed with steroids. The patient will find that the use of the steroids will relieve the symptoms and they feel very comfortable. And even though it's a time for them to stop the use of the steroid, which we usually use only for a short duration, they will continue buying the drops from the pharmacy and use, and subsequently lead to steroid-induced glaucoma, which is symptomless. The patient doesn't feel anything. And subsequently, when they lose their vision, they come for checkup and we find that it's secondary glaucoma. The next cause of secondary glaucoma is a swollen cataract. Sometimes a patient has a cataract and does not want to remove it and wait until the cataract becomes mature. So when the cataract becomes mature and subsequently hypermature, it becomes swollen and gives rise to secondary glaucoma. In this type of condition, it is an emergency for us to remove the cataract. I mentioned about the diabetes causing secondary glaucoma earlier. So how does a patient feel when they have glaucoma? So in this situation, you can see when a person has normal vision, like in this picture, you can see all over from one corner to the other, the full picture. But when the patient has early glaucoma and the patient doesn't feel it, doesn't know it, because only the corners of the pictures can be obliterated and affected because this is peripheral vision affected. As the glaucoma progresses, you can see the peripheral vision becomes more affected and only limiting more and more to the central vision. So when the patient presents with extreme glaucoma, that means to say only an island of view left. This is the time when they go to an unfamiliar place, they start knocking into things, or when they're driving, they find that they start knocking into people. So patients who have extreme glaucoma with advanced visual field loss, usually we advise them not to drive because they are posing a danger to themselves as well as posing a danger to others. So how do we diagnose glaucoma and how do we monitor the progression of glaucoma? So the two important parts that we need to examine the patient besides checking the intraocular pressure is the nerve that comes out from the eye as well as to check for the visual function. So we look at the size of the nerve and we follow the progression of the size of the nerve. Just by looking at the size of the nerve will let us know, will tell us roughly at what stage of glaucoma the patient is. And when the patient is early without any symptoms, sometimes they have just pressurized, they may not show any visual damage. But as it progresses and becomes advanced glaucoma, you can see more and more visual field get affected as shown by these black areas and only small islands of field are left. So how do we diagnose glaucoma? We know that we need to go to check, see an eye doctor to check for glaucoma, but how do they normally do it? So this shows that the patient has to be examined at the slit lamp. This machine is called a slit lamp, and this is the nerve at the eye which we look into it. This is one of the things we look for when we check the patient for glaucoma, and we use this slit lamp to also check the patients for intraocular pressure. So how do we check the pressure in the eye? This is one of the most accurate ways of checking pressure. We put anesthetic drops inside the eye, and then we put a special dye which is called fluorescein inside the eye. And subsequently, we use a cold blue light like this, and we put it using this tonometer to touch the patient's cornea. And from this, we can do the reading for the eye pressure. So this is one way of measuring intraocular pressure. Then we look at the fundus and we look at the size of the nerve to see whether it's large and how big is it. And usually, if this size is larger than the normal, we have considered patient as having a large optic nerve and making the patient a suspect for glaucoma and need further examination. For patients who have got glaucoma, we monitor the progression of glaucoma by monitoring the size of this optic nerve. The most important part of monitoring glaucoma and making a diagnosis of glaucoma is doing the visual fields or what we call automatic perimetry. A lot of times patients hate this test because they need to do a lot of concentration to use it. But I have to stress that this is the most important part of the eye to tell you whether your glaucoma is progressing or not. Because an intraocular pressure doesn't give you much of an indication of whether you're progressing or not, unless you show that you have increased in pressure. Even though the pressure may be within the normal range or appears to be controlled by eye drops, the patient can still progress. And the glaucoma which progresses can only be picked up by monitoring the visual fields. That's why we have to stress to the patient that you must do the visual fields at least once a year. Newly diagnosed glaucoma must have the visual fields monitored about 2 to 3 times until the visual fields are stable. Then we can progress to one field a year. And here we use a special automated perimeter whereby we put the patient at the machine and we test one eye at a time. It is a very taxing test, but it's a very accurate test if done properly. And it gives a lot of information. Next, we use a machine to check the structure of the eye. But in glaucoma, we always tell the patient that the structural damage happens first before the visual function happens, functional loss happens. So in this test, either it's an OCT or GDX or HRT, all three machines use the same principle whereby they measure the thickness of the optic nerve and they check for the thickness of the nerve fibers in 4 different quadrants. And here they show to you how much are the thickness. And when there's a tremendous drop in the thickness of the nerve, and it must correlate with the functional loss as documented by the visual field for any patient with glaucoma. Patients may have a decreased thickness in the optic nerve shown as OCT, but they may not have glaucoma. It could be due to some other reason. So definitely for making a diagnosis of glaucoma, you must be able to correlate the structural loss to the functional loss. There's another machine that we can use to check the drainage system of the eye. This is a machine which we use for anterior segment assessment. But having said that, we can measure the intraocular, we can measure the structure of the angles of the eye by using a lens at the slit lamp without having to make use of this highly expensive equipment. So here is a summary of what are the important tests that we have to do for patient. First, after taking the intraocular pressure, we need to take a picture of the optic nerve, or follow the size of the optic nerve. But following the progression of the size of the optic nerve can give us an indication whether the patient is progressing or not. Second, we need to do the structural measurement. This is OCT, this is the HRT, and this is the GDX. All these three machines measure the same thing. They measure the structure of the optic nerve or the retinal nerve fiber layer. And this is the visual field, which is done by the visual field automated perimetry. And out of this, all of them must be taken into combination for us to make a diagnosis of glaucoma, as well as for us to monitor the patient properly. So having said that about all the treatment and diagnosis, now we talk about the treatment. The main reason why we need to treat the glaucoma is that we must preserve maximal visual function throughout a patient's lifetime, without sacrificing his quality of life and at a sustainable cost. We say the maximal functional vision to be preserved because it depends on what stage the patient is diagnosed with glaucoma. If the patient is diagnosed at a young stage of you have glaucoma, say about 40 or 50 years old, probably with the life expectancy in Malaysia of a patient about 72 years to 75 years, it means to say the patient will have about 30 years more in the lifespan. So in that 30 years more for the patient to live, it's important for us to be able to preserve the function, and for them to preserve the function means they must be able to control the glaucoma, and to control the glaucoma, we have to start treatment. And without the quality of life, we don't sacrifice life, so we make sure that we control it well, and at a sustainable cost, because I usually tell my patient, glaucoma is an expensive disease. Each medication is very expensive. And if the patient needs to use up to 4 or 5 types of eye drop, it can cost the patient about $400 or $500 a month just to spend on treatment for the eyes. And this is treatment is for lifelong. What other types of treatment do we have for glaucoma? As mentioned earlier, we have the eye drops or pharmaceuticals, which can be rather expensive. So sometimes the patient can be not complying with the medication, or the patient may have side effects from using the medication, or the patient doesn't have difficulty putting on the eye drops, like patients with rheumatoid arthritis or arthritis where they have problems putting eye drops into the eyes, or the patients are very forgetful and have nobody to stay with them to help them put the eye drop. Then we may consider trying to control the pressure by other different means, like doing laser surgery, like doing the selective laser trabeculoplasty. However, we must stress here that laser trabeculoplasty sometimes lose its effect after a few years. And then we can go on to ab internal surgery. There are many different types of surgery. We have ab internal surgery, and we have the normal filtration surgery, whereby we create a pathway for helping the fluid to flow. And worse to worse, for difficult glaucoma cases, we even put a drainage device. So what we have to stress here is that what kind of treatment we give to the injured patient is individualized. That means to say that the treatment for patient A may not be the same as a patient B. So we have to see what are the requirements of each patient. A lot of times I have patients who come and say, oh, my brother or my sister is using this eye drop and told me to use this eye drop as well. Yeah, but is this a simple eye drop? We can maybe use the same eye drop. But each patient responds differently to the same type of eye drop. And each eye may not respond the same to the same eye drop as well. Whatever kind of treatment we use for the patient, we must stress that even 1 millimeter mercury of pressure, we are able to bring the pressure down, makes a significant difference, because that will mean that the pressure is much lower, and therefore we are able to control the intraocular pressure more, and which subsequently leads to less damage for the eye. At this moment in time, many of you may have heard about minimally invasive glaucoma surgery, or mixed, which is very popular nowadays. And this makes use of the stents, which is inserted into the drainage angle. And this is the less invasive type of surgery. But having said that, usually very advanced glaucoma patients may not benefit much from this minimally invasive glaucoma surgery. So now we know that glaucoma can steal our eyesight if we are not careful, if we don't diagnose early, and we don't take care to control the pressure and prevent progression. And we also need note that glaucoma may present itself at a late stage without any symptoms. So what you need to do is to prevent yourself from becoming blind from glaucoma is that you need to go for regular comprehensive eye examination. This means that you must go for your eye checkup depending on your age. How frequently you do it depends on how old you are, whether you have other symptoms like trauma to the eye before, or whether you've got diabetes in the eye. It is important for us to note that sometimes the eye sometimes it's important for us to note that at one stage the glaucoma may seem okay. It doesn't mean the rest of the life it will not happen. Like sometimes when you go for a checkup like 40 years, you may not show any signs of glaucoma. As time goes by, the glaucoma may creep in. So it means that for the rest of your life, if you have all those uh, uh, contributing factors or risk factors, you should be getting your eyes examined regularly. Most patients will know that they can go for wellness checkup because they're very important for them. Is they must check that they have no heart problems, so they don't die of heart attack. They must make sure that the blood pressure is controlled. They go and make sure that they meet the stents and the stents are working. Everybody forgets that they need to go for an eye checkup as well. So important for the patients not only to go for a regular physical checkup, they should go for a comprehensive eye checkup as well. And once we detect the patient to a glaucoma at screening, we must start treatment immediately. So now, I think I've come to my last slide. So we need to know when to go for a checkup. So because the earlier the diagnosis is made, the earlier we detect the damage, and the less the damage will be, and the more the vision will be saved. So before the age of 40, you may consider having your eyes checked up every 2 to 4 years, unless you have got history of trauma, high family history as well, or you have conditions like migraine and diabetic retinopathy or hypertension or any physical uh, conditions that may give rise, medical conditions that may give rise to higher risk of developing glaucoma. After the age of 40 to about 60, maybe about every 2 to 3 years, but more important is after the age of 60, you should consider to have your eyes checked up every year if possible, if not every 1 to 2 years, because this is the time whereby you may develop cataract. You want to know whether your cataract is progressing. You may develop macular degeneration as well, and most important is you may develop glaucoma as well. And as we know, glaucoma damage is irreversible, so it's very important for us to pick up glaucoma at an early stage. So having mentioned all these things, what I want to summarize is, we know that glaucoma is an important cause of irreversible blindness. The earlier we detect glaucoma, the earlier we can start treatment, and thus we can lessen the amount of damage to the nerves, and we can save the vision as much as possible, because whatever damage happens to the eye from glaucoma is irreversible. So we must all remember to go for your screening in order for us to avoid the snake teeth of sight. Thank you for your attention.
Thank you, Dr. Linda, for the wonderful and informative talk on glaucoma. I think I've learned a lot on glaucoma already. So let's go to the questions. We have quite a number of questions. All right. First, okay. Question: can cataract leads to glaucoma?
Yeah, I mentioned earlier that cataract can lead to glaucoma in different ways. It depends on the cataract. The one that I mentioned earlier was a swollen cataract. That means to say the cataract becomes very big because it's hypermature, means it's overripe, and because it's overripe, it absorbs the fluid inside the eye and it expands and becomes swollen. And because it becomes swollen, it causes blockage to the drainage system. And when it causes blockage to the drainage system, it causes sudden rise in intraocular pressure. Cataracts can also give rise to glaucoma when we have what they call picolytic. That means you say again it's a hypermature cataract, but in this situation it's not because the cataract is swollen. In this situation where you got picolytic glaucoma is when the proteins or the cells from the cataract leak through the capsule into the and because of that the cells block the drainage system. Then you can get a sudden increase in pressure. And then the other one where cataract or no cataract, just lens can cause glaucoma is when you have trauma. I remember having a case whereby this old man was walking and somehow the coconut fell on his head. He didn't die from the coconut falling on his head, but the lens, which was a bit partly cataractous, fell into the back of the eye. That means it dropped out of the normal position. And this gave rise to secondary glaucoma, and this had to be lens had to be removed because it caused secondary glaucoma.
All right. Next. Is there any cure for glaucoma? How can one prevent from getting glaucoma?
There is no cure for glaucoma at the moment. There's no food that you can take that can prevent glaucoma. One of the favorite questions that patient will come without fail with being Asian patient, they will ask us, Doctor, any food to prevent for glaucoma? Sorry to say there's no food, no medicine at the moment for curing glaucoma. So it's important to prevent yourself from having glaucoma, be aware of glaucoma, go for screening. And if you have got glaucoma, to be compliant with the treatment.
All right. Doctor, why do some patients with glaucoma some patients use one drop, some patients use four drops and 2 to 4 drops? Is there any complications, as in more severity if they use more drops?
Okay,
And is there any
to answer
complication?
that question, you have to know the status of the patient. When the patient comes to see you, say assuming the patient comes to a pressure of 28 or 30 millimeters, it depends how much the pressure is. So when we see the patient, we usually start with one eye drop, which is called monotherapy. Monotherapy means using one eye drop. And we give the patient like about 30% drop in the pressure. So let's say after using one eye drop and we find that the pressure doesn't come down, then we have two options. Either we switch the medication to a different type of medication and see whether it works, or we find that maybe we add another medicine. So from one medicine, it becomes two medicine. So two medicine, if we find that the pressure is well controlled, we stay at two medication. But if we put two medication and still the pressure doesn't come down, not controlled, we put another medicine. Then it becomes three medication. So the maximum medication is usually about 4 types of medication because it all comes from different categories of medicine of the medication. Not all the medications are the same because we have medicine that help us to decrease the production. We have medication that help us to improve the flow of the medication of the eye of the first. So if we come to there may be a situation whereby the pressure is not under control, then we use more and more medication. Having said that, we also have patients who progress even when we use medicine. So let's say we use one medicine, whether the pressure is controlled or not controlled, but you can demonstrate that there's a progression in the visual field defect, then we will have to add medication to bring the pressure down. All in all, we have to set the target pressure for each patient. That's why we say that glaucoma is an individualized treatment. So when we set the target pressure and the patient does not achieve the target pressure, we may end up having to add further medication.
And does glaucoma gives any effect to other parts of the body?
Yes, certain type of glaucoma may cause side effects. That's why we need to know whether the patient has got a heart problem or heartbeat problem, like the patient may have a slowing of the pulse rate, they may have heart block. So we have to be very careful when we use beta blockers because those beta blockers that the patient use for asthma or for hypertension control, they may affect the eyes as well. Then we have to see whether the patient has asthma. Again, beta blockers is non-selective. It may cause a patient to have more wheezing, more asthmatic attacks. So when patient have got these two, we have to avoid beta blockers. And then most of the time when we use the what do you call it, the prostaglandins, they may cause pigmentation of the eyes, they may cause dark eyes, tender eyes or dry eyes. And then we have got patients who use the alpha agonists, they may cause sleepiness, drowsiness, or allergies. So we have to watch out for side effects of the medication. So allergies. So we usually tell the patient what to expect from the use of the medication, so they can watch out for all these side effects. Yeah.
All right. Um, just now, doctor was saying long-term usage of steroid will cause secondary glaucoma. So, how long is the time frame of to use a steroid?
The time frame actually depends on what the condition was that requires the steroid. But the important thing is that you must use it under monitoring. That means to say that there are certain conditions, like certain conditions need to use long-term steroid, like some form of inflammation in the eye, like uveitis or chronic granulomatous uveitis. Some form of inflammation in the eye that may need a long-term steroid use. You use the steroid, but it's all right, but you must check your pressure, your doctor to check your pressure regularly. So that means monitoring is important. If the pressure goes out of control, then you have to use the steroid.
Right. Is laser trabeculoplasty is a good option?
Laser trabeculoplasty is an option which you can consider, the patient can consider as number one. It's a young patient, lady, who has glaucoma on medication, wish to get pregnant. So you know, all glaucoma drops have not been proven to be safe during pregnancy. It has not been safe to somebody who is taking on. So when a young patient comes to you and tell you they want to consider pregnancy, you have a baby, you have the patient whether they're keen for surgery. If they're not keen for surgery, they may consider selective laser trabeculoplasty, which may help you to cut down on to be able to control the pressure without medication. Having said that, in a patient on 4 or 5 drops or maximum 5 drops, selective laser trabeculoplasty may not be able to control the pressure.
Alright, go to the next question. Doctor can explain on congenital glaucoma management and the eye drop.
Oh, congenital glaucoma actually is a long lecture by itself. It's a totally separate kind of glaucoma. So to summarize it all, I would say congenital glaucoma form of treatment is surgery. What causes congenital glaucoma, we don't really know. Maybe it could be due to what you call that rubella syndrome, because a lot of times nowadays we hardly see rubella syndrome anymore because patients, most school children will have an MMR, isn't it, the vaccination, rubella, mumps, and measles kind of vaccine. So you hardly see congenital glaucoma anymore. But patients who get, the mothers who get infection during the first trimester of pregnancy may have a high risk of getting congenital, the baby may have congenital glaucoma. So most of the times it's because the congenital glaucoma happens because of the drainage system of the eye of the child. So for the child, usually it is surgical treatment. And it's not, it's life, the condition is lifelong. And you need to treat the glaucoma and then after that control the glaucoma, the pressure, and also to make sure that the child grows up without developing lazy eye. So it's not just a pressure alone. For the child, you have to talk in terms of the vision, and then you have to talk in terms of a follow-up care and so on. Because sometimes congenital glaucoma may not be just glaucoma alone. The child may have congenital cataracts as well. So it's a complicated situation. So it needs a long discussion, just a new topic by itself.
Alright. Can glaucoma occur bilateral or at only one eye? Normally based on doctor's experience.
Yeah, I mentioned earlier, just now I said glaucoma can happen at 2 eyes at one stage, or you get glaucoma one eye at a more advanced stage than the other. And if you get only glaucoma in one eye, then it means it rings a bell to us. Did you have a trauma injury to the eye before, or something has happened to the eye before? If you only one eye, majority of the time is bilateral. Even angle closure glaucoma, when we treat angle closure glaucoma, we tell the patient, we treat this patient with laser iridotomy, and we tell the patient that there's high chance they will develop glaucoma in the other eye as well. So we also do prophylactic treatment for the other eye.
I think this will be the last question. Is glaucoma contagious from one eye to another?
Everybody will have glaucoma. Whoever comes to my clinic will have got glaucoma.
Okay.
No, glaucoma is not an infectious disease. Now, glaucoma is a condition which develops because of the drainage system of the eye. So it is not contagious. It doesn't spread by looking at another person's eye. It doesn't spread. It's not spread by touching the things belonging to another person. It's not like a bacterial conjunctivitis or viral conjunctivitis. So it's because related to the drainage system of the patient.
So I think that's all. Perhaps, Doctor, can we any take-home message for our fellow audience before we come to the end of the session?
My take-home message is that number one, be aware of glaucoma, which is a possibility that can happen as you grow older. It's a disease of older people, and go for your eye checkup if you at least once a year. Even though if you don't have a predisposing factor, you should go for a regular checkup because some patients develop glaucoma without any factors. But if you do have factors like family history, diabetes, injury to the eye, or using steroid for a long time, you should have considered doing a checkup for glaucoma at least once every 2 years or once every few, depending on how old you are. And for those people who have got glaucoma, just remember, glaucoma treatment is individualized. Try not to follow the treatment of your friend or brother or your sister, because both of you may not need the same kind of treatment. As I stressed, the glaucoma treatment is individualized, and it depends on your target pressure and how whether you are achieving the target. Number three is, if you have got glaucoma, be compliant with the treatment. Make sure that you don't miss eye drops, because when you miss your eye drops, that means to say the pressure is not under control. And when the pressure is not under control, your eye pressure will fluctuate. It is the fluctuation in the eye pressure that causes the damage, not just the high pressure. It's a fluctuation in the pressure will subsequently cause damage to the optic nerve, which is irreversible.
All right. So thank you, doctor, for giving us in depth about glaucoma. I hope with this we practice ourselves to get a routine eye checkup done based on the years of every individual. And thank you so much for tuning us and staying up to now. If there's any question, you can type it at the comment section and we will reply the comments. Thank you so much. Thank you.